There we go. So if you remember when we went through imaging for ring last year, we're back all the way up to chapter, I think, 5. We did a bit of a review on chapter 5 through 8 and 9. And we're not going to back up quite that far with X-ray production. We're just going to talk about X-ray emission and things to control X-ray emission. Then we're going to press on into imaging. And what we're going to do for the rest of this semester is we're going to do it twice. So we're going to go all the way through imaging once. Well, isn't that cute? I have no clue as to what I just did.
What happened to Trina the other day?
Oh, yeah,
Let's do it again.
you can just slide that bar over.
Slide from
Yeah,
here?
right.
Okay. All right. There we go.
I was like, she did something, but I don't know
Yeah.
what it was.
Yeah, it's a little different. So what we're going to do is we're going to go all the way through imaging once. Holy smokes, it's dark in here. We're going to go all the way through it once, and then we're going to test on it. So we're going to be pretty meticulous this first time that we go through it. And that means that it's going to be a few weeks before we test. But we'll test on it, and then we'll go back through it one more time and test on it one more time. So that'll take us up to the end of the semester. So again, this imaging is probably the most complicated portion of the registry, so we cover it more than anything else in the program. I'll put a little bit of light in here because I have a feeling I'm going to start hearing heads hit the desk if it's that dark. All right, so X-ray emission, things that control X-ray emission. You got your KVP, you've got your MA, your time, you've got your generator phase, all that stuff we're going to run back through. So what generally we're talking about in imaging is quality and quantity. So factors that affect image quality and factors that affect image or the quantity of X-rays. So factors that affect radiographic quality and quantity, as well as things that affect the beam quality and quantity. So generally when we're talking about emission, we're talking about beam quality, right? And you got to remember that beam quality and radiographic quality are inversely proportional. So we'll get into that. So X-ray quantity, again, we're talking about beam energy here. So we're talking about intensity. Anytime we're talking about intensity, we're talking about numbers and what controls, what's in direct control of your numbers. Mass, right. So that is your quantity is controlled by the tube current. So the more electrons you send across the tube, the more X-rays you create. Now, when we send electrons across the tube faster, that's KVP, right? KVP changes the attraction between the cathode and the anode so that the electrons travel across the tube faster, hit the anode harder, but what we wind up with is as we increase KVP, we also get an increase in output as well. So why is it we say that mass is our control of quantity and not KVP? Because KVP actually affects quantity more so than mass.
It's hard to measure it.
It's hard to measure it. It's hard to tell exactly how much of a change you're going to have because as we increase KVP, what we do is we think mentally about your brim spectrum, right? The brim spectrum was that thing that's like an elongated bell curve. And when you increase your KVP, think about everything that happens with that brim spectrum. The end that goes towards a high energy side extends out further, so you get a lot of X-rays, a lot of increased number of X-rays, not just directly above, but also on that high energy end. So you don't really know what's going on with it, right? But with mass, it's just a numbers game. If you increase your number of electrons you send across the tube by just one, then you're going to create exactly one more X-ray photon, right? If you double it, you're going to create exactly double in all the same energy levels that you created at the same KVP. So with KVP, you change a lot of stuff. You change average, you change peak, you change the imaging characteristics of the X-ray beam. Everything changes, whereas with mass, only one thing changes, and that is numbers. So that's what we use to control the quantity of the X-ray beam because it's so predictable. So it's measured in gray, in air. Sometimes we use Rankine. Whenever, if you're ever present while the physicist comes in and they run QA, quality control, really QC, on your machine, what they'll do is they'll put an ionization chamber on the table and they'll shoot it and they'll measure the KVP, they'll measure the mass, and the mass is equivalent in gray or Rankine. So that's your ionization in air. Whereas Rem and Rad are in tissue, right? Rankine is in the air. So really what you're measuring is the output of the X-ray tube before it strikes the patient. So a lot of stuff here. And some of this we already talked about. Mass directly affects quantity. If you increase mass by 15%, you get 15% more X-ray photons. Increase by 50%, that's half again as much as what you would have. So you had 100 mass, you go up to 150 mass. You're going to create half again as many X-ray photons. Whereas with KVP, it's exponential. It's direct. So if you increase your KVP, you increase your quantity in the same direction. You increase, but a 15% increase in KVP equates to how much of a change in exposure?
You don't know.
You do know.
Oh, did you say KVP?
Just KVP. If you don't do anything but increase KVP, how much of a change in exposure do you have?
Is that how?
It increases by a factor of 2. So your mass needs to be cut back by a factor of 2 to maintain the exposure, right? So it's exponential. 15% change in KVP equals a doubling of the exposure, okay? So it's exponential. It goes in the same direction, but it's exponential. Machine phase. Machine phase changes your exposure as well. As we change from a single phase to a 3-phase, what happens to our pulses? Remember, it's been a long time, but what happens to our pulses?
When you go from which to which?
Single phase, 3-phase.
There's less of a,
It doubles it
yeah.
because it overlaps. The pulses overlap. And again, right away you might select a question that if you go from single phase to 3-phase, it changes by a factor of 3, which would be logical, but it doesn't work that way. It doubles the output. But what also happens in the beam spectrum when you change from single phase to 3-phase, you get an increase in output, so quantity, the height of that bubble goes up, but what else happens? Energy goes up higher, right? So we get a higher average energy. The peak remains the same, but we get a higher average energy. So again, the imaging characteristics of the X-ray beam change as well. So can we affect a change in exposure? If we needed a doubling of the mass, could we do that with machine phase? Absolutely. But it changes your imaging characteristics of your X-ray beam. So we don't want to do that. So machine phase affects quantity. And it changes as you go from single phase to 3-phase. It increases your quantity, so it goes in the same direction, but it's not a 1-for-1 direct correlation between exposure and the number of photons that we get. So filtration. What is the purpose for filtration? Why? Remember. William Rollins invented filtration to remove low energy X-ray photons. And what did that help with?
So it increases your average energy?
It increased average energy, but the purpose for the filtration, that's a benefit of the filtration, but the purpose for the filtration was to get rid of those low energy photons that would just absorb inside of the patient's body and contribute nothing to the image, right? So it was really radiation protection. But what happens with filtration is by getting rid of those low energy photons, what are you left with? Higher average energy. Unfortunately, what we do lose is some we'll lose some of the X-ray photons that would contribute to the overall mass, right? So our numbers, our quantity is inversely proportional to the filtration. The more filtration we have, the less numbers we have, right? So with mass, it's a direct relationship. With KVP, it's exponential in the same direction. So it's a direct exponential relationship. With machine phase, it really is kind of direct in that it goes in the same direction. But again, you've got changes in the imaging characteristics, whereas filtration, it inversely affects quantity, so that as you increase filtration, we lose a lot of numbers. And what we're going to have to do is reintroduce some of those numbers in a lot of cases. All right. So more changes in source to image distance. As we increase SID, we move the X-ray tube away from the patient further and away from the image receptor further. What do we get? You lower the numbers. Why does it happen though?
Inverse square.
Convergence of the central ray, right? So if we were to take these things and put them all the way back at the back of the room, how big would our projected light field be? It'd cover up the entire wall. But the problem is that as they cover up the entire wall, the light that is projected right here would be spread out more so. So what would happen to the brightness? What would happen to this blue coloration?
It would go down.
It decrease, right. So everything would decrease because that quantity of light has to spread out over a larger area, right? In imaging, in X-ray imaging, if you do that, the same thing happens. You back up the X-ray tube from 40 to 72 inches, and it spreads out. But again, going back to Rollins, what was the other thing Rollins invented? Not just filtration, but it's been a long, long time. It's a full year. We just went through this with the freshman students. Automation, beam restriction, right? So as you back up that distance, what you have to do is you have to beam restrict, right? So you take all that light and you spread it out, and then you just use a fraction of that light, right? The X-ray is the same thing. You spread it all out, but you just use a portion of it. So your intensity in just that area for a chest X-ray is going to reduce drastically, right? Since that intensity, those numbers drop, then what do we have to do with our technique? Increase our technique, right? So we'll talk about all that for the next test. So what about object to image distance? As we increase our OID, so our SID remains the same. If we increase our OID, what happens?
You get magnification.
You get magnification, but in as much as we're talking about quantity, is there a change?
No.
Is it?
Yeah.
Yeah, there is. There is, a little bit.
Closer, so we get more.
Well, okay, yeah, you're talking about patient exposure, I'm talking about radiographic exposure. Okay. What about the air gap? What do we say the air gap, how can we use the air gap?
It makes them miss the.
Right, this wide angle scatter radiation will miss the image receptor, so it really wouldn't have much of a place in hand X-rays, but in lateral C-spines, some of your departments, probably little bitty towns, might not use grid for lateral C-spines because the distance, from the shoulder to the C-spine is far enough that you get a natural air gap. In with computer algorithm and CR and especially DR, you might not see a whole lot of difference in a C-spine taken with a grid and C-spine taken without a grid utilizing the air gap. In film, back in the days of film, before you could apply high contrast algorithm to the image, I can tell you can see a difference. The air gap was, I always thought it was pretty hokey. you could see gross anatomy, but as far as fine detail and a really high contrast, you'd have to decrease your KVP significantly. But the theory behind the air gap is that it works like a low ratio grid because the wide angle scatter radiation is going to miss your image receptor. So if that scatter misses the image receptor, then what happens to your numbers as they strike the image receptor?
It's gonna
They
decrease.
decrease, right. Right, so your intensity at the image receptor decreases. Not really the intensity emitted or created, but the intensity at the image receptor decreases. Same thing with grid ratio. As you change grid ratio, what's the purpose for a grid?
Absorbs the
Decrease your-
low energy.
Not necessarily low energy. It's gonna be low
Yeah.
energy by virtue of it having interacted inside of the patient, but the
Yeah.
purpose is really to absorb that wide angle scatter radiation, right? And if it absorbs that scatter, the exposure to your image receptor decreases again. So if you go from a low ratio grid to a high ratio grid, what can we say about high ratio grids versus low ratio grids?
You need higher technique
You need higher technique, why?
because it decreases exposure on
Because it decreases the exposure to the image receptor. So the higher the ratio grid, the more efficient they are, the more scatter radiation they absorb. Realistically, the more primary, or it's really secondary beam, but non-scatter radiation it absorbs as well. So we tend to think of grids as just absorbing scatter radiation. It really absorbs primary, or the unscattered radiation as well. Because you take a piece of lead and you stick it, even if it's a very thin piece of lead, you stick it in the X-ray beam, it's gonna absorb it, right? So the more lead you put in your grid, the more absorption you get, primarily of the scatter, but secondarily of the secondary X-rays, the penetrated X-rays. So as grid ratio goes up, it's gonna be inversely proportional as grid ratio goes up, the exposure to the image receptor goes down, so you got an inverse relationship there. So changes in tissue thickness, you go from a relatively thin patient to a relatively thick patient, what do you get?
More scattered?
You get more scatter, right? So as thickness goes up, what are you gonna use?
More technique.
more mass.
Before we get there, what are you gonna use?
Grid.
Grid, right? So you get to a grid, we hadn't changed our technique yet, so we, with the increased thickness, we're gonna get more scatter radiation. Some of that scatter radiation is gonna absorb inside the patient, right? So first off, before it exits the patient, you're gonna have less intensity before it comes out of the patient, okay? And then we're gonna throw a grid in, and what's gonna happen to your exposure? It's gonna decrease even more. So again, you're gonna need to increase something. But if you change nothing, then your exposure to your image receptor is gonna drop dramatically. Here's the thing. Some of y'all might make this leap between patient thickness and scatter radiation, and exposure to the image receptor. What do we say scatter is?
Noise?
It's noise, and it's an unwanted density, right, it's an unwanted density. So, I've had students in previous years, think, okay, well, scatter radiation is an unwanted density. Thicker patients create more scatter radiation, and therefore, thicker patients create more scatter being an unwanted density. They'll make that leap, they'll make the connection between thicker patients and more density. Doesn't work like that. Because it's true that as tissue thickness increases, we get an increase in scatter radiation. A lot of that scatter is going to absorb inside of the patient, but the percentage of what exits the patient is going to be more scattered than penetration. And therefore your density goes, or your exposure or density goes down. Okay, so don't make that leap between increased thickness, increased scatter, increased density. True, there's separate statements. It's true that scatter is an unwanted density, but your density is not gonna go up necessarily because you increase scatter. Okay,
So your
you see what I'm
density's gonna
saying?
decrease, increase scatter.
Well, not necessarily. Your density is gonna decrease if the increase in scatter is because of an increase in tissue thickness.
Okay,
Okay, if we're talking about a change in tissue density in the same thickness, let's say we've got a replacement of bone with soft tissue, then we very well may see an increase in radiographic density because of loss of subject density.
okay.
Does that
So
make
it just
sense?
depends on what changes.
It depends on what
If
changes,
it's, if
right?
it's the part thickness, then the
Write that
density
down.
decreases.
Right. So, but again, and we'll talk about this, you know, more and more, but if the change in thickness is due to a decrease in density, and the decrease in density is air, then you're gonna have a dramatic increase in radiographic density, okay? So in that case, think about a patient who's bloated. You know, they got a great big distended abdomen, and in one case, one patient, you've got ascites. What's ascites?
Fluid.
Water, fluid, right. As opposed to the other patient is really big bloated because they've got a bowel obstruction. What's your telltale sign that the patient has bowel obstruction?
Your air.
Air, right. So, do you think you're gonna see a difference in the image between those two patients? With the patient with the air, it's gonna appear dark, as opposed to the patient with the ascites, it's gonna appear very gray, right? So, a lot to consider in tissue thickness and tissue density there. So tissue density, you know, difference in tissue types is inversely proportional change in density, intensity. Okay,
Did
so,
you skip one?
pardon?
Did you skip one?
Oh, that's it.
Oh, no.
Factors that affect quantity of the image receptor. So you got post-patient collimation. Post-patient collimation really works like a grid. And it's usually used, the most common place you see it now is in CT. So it doesn't really apply that much to us, but there might still be some places out there that use what they call scan projection radiography. Have you ever seen the X-ray image that's created off of a CT that doesn't look like a CT? It looks like an AP or a lateral. No? Okay.
Yeah,
It's what they call a scanogram, and that's what they use it for. That's where the most common place that you're gonna see scan projection radiography. But there are dedicated chest units that use the same technology. And what they do is they take and they collimate tightly to a fan-shaped beam, so the beam is very tall, because you're just doing chest x-rays. It's very tall, but it's very thin. And what it'll do is it'll scan across the patient from one side to the other, to the image receptor. And what they'll have is pre-patient collimation to make it a very thin x-ray beam, and then post-patient collimation to get rid of some of that scatter before it hits the image receptor. So they use that in scan projection radiography. I've never worked with a unit that is a scan projection. I've worked with dedicated chest units, never seen a scan projection unit. You do see them in CT though. That's how CT really works. Then it works like, you know, kind of like a grid. Then grids, scatter cleanup, we already talked about grids. So beam restriction, we talked about that. Beam restriction reduces quantity by reducing the prevention, or by reducing the creation of scatter radiation. All right, so the purpose for collimation is, the stated purpose and the original purpose for collimation is to protect the patients, patient protection. It's beam restriction. But secondarily, what we get is a reduction in the scatter radiation that we create. Okay, so again, back to scatter radiation. Scatter radiation does what? Gives us a layer of unwanted density, right? So if we prevent that scatter from being created, then what's going to happen to the exposure to image receptors? If we
Less.
shoot,
goes down.
there you go. So if you shoot one image with wide open collimation, you know, if you were to take a KUB on a patient, and you don't change your technique and you collimate in for an AP of L-spine, then what's gonna happen is you're gonna have less radiation exposure to your image receptor. So, you know, if you're ever messing around in the x-ray room, you just wanna play around with some stuff, you can kind of create a patient. Take saline bags, and just lay it on the x-ray table and put something in the middle that would represent anatomy, you know, and saline bags do too, but they just create scatter. Take a basin of water, you know, one of those big square plastic tubs of water, and you put 2 of them and put something in the middle, in between them. And so it would represent kind of like a KUV, and shoot it with the x-ray beam wide open, and watch what your machine shoots out with. And then collimate in just to the area right in between and shoot it a second time and see if you got if your technique changes at all. If your phototime, it should change. So with beam restriction, it prevents scatter radiation from being created, so it prevents a layer of density from being applied to the image receptor. So what would that do to your exposure at your image receptor? We just talked about that. It would reduce it because you have prevented that scatter radiation from being created. And of course, you got collimators, cones, diaphragms, and all that. All right. So, questions on quantity? Excuse me. And KVP is what we use to control our quality, our beam quality. Remember, KVP is not the best measure of beam quality. Half value layer is, and we'll kind of run through that exercise here in a minute, but it is what we use to change beam quality. When's the last time you changed out filtration? Never, right. Never done it. So, you know, it's kind of irrelevant for how we control quality. Quality does change over the life of the x-ray tube because filtration does change in your inherent filtration because of tanning, right? But what we use to control quality is just simply KVP. So as KVP goes up, the more penetration we have. This is beam quality, this is not radiographic quality. The more penetration we have, and the beam quality goes up. So an x-ray beam that doesn't penetrate, of what quality is that?
Well,
It's very low quality, it's of no quality. If it doesn't penetrate anything and we're trying to create an image, what do you get if you shoot a patient with an x-ray beam that just doesn't go through?
Just wait.
You're giving them a dose, that's all you're doing, you're treating cancer, right? So in imaging, if it doesn't go through the patient, then it's of no quality whatsoever. So KVP controls your quality. Filtration also has a proportional relationship. As filtration goes up, we also get an increase in quality. We get a decrease in quantity, we get an increase in quality. And that is where your half value layer comes in. You remember, I can draw this out if you don't, and if a marker that works, but you remember kind of walking through 2 different x-ray rooms and you shoot with exactly the same technique. You got one room, or in both rooms you're shooting maybe with 70 kVp at, you know, you pick a mass, maybe 20 mass, and in both of those cases you get 100 Rankine of exposure, because again, you're measuring in air. So it looks like you've got exactly the same exposure in the two, but if you put a single layer of aluminum into both, and it's 1 millimeter of aluminum into both x-ray beams, and you've got one that it cuts it down from 100R to 50R, that's its half value layer, right? 1 millimeter of aluminum cut its intensity in half. But if it only cuts the other one down to, let's say, 75 instead of all the way down to 50, then what you're left with is more penetrating x-rays in the second room, and therefore you get a higher quality. Your half value layer would be maybe 2 millimeters of aluminum instead of 1. So KVP was identical in the two, but what you were left with in the second one was higher exposure after the aluminum, and therefore it's a higher quality x-ray beam, right? So in that way, half value layer is a better measure of quality than what KVP is. So half value layer takes into consideration filtration. You may be thinking, well, how could that possibly be that you make the exposure, you have exactly the same exposure with the same technique, but the quality is totally different? Well, that's because whenever the physicist comes in and works the quality control in the room, you know, the one that had a single layer of aluminum as a half value layer might be a brand new x-ray tube. But what happens over the years as you use x-ray tube? Tanning, right? So what is tanning?
Filtration.
Filtration, right? So what's gonna happen is every year he's gotta come in and he's gotta run those tests, and he's gotta make sure that the exposure that you make is representative of the settings that you set. So he's gotta read the quantity and quality as it comes out of the x-ray tube. So as the tanning goes up, then what you get is more absorption in the x-ray beam. So what is he gonna have to do?
Go up on the technique.
He's gonna have to go in, and your technique as you read it remains the same, but he's gonna have to tweak the machine and make it shoot with the same mass value that it shot with before, right? So over the years, what you get is an increase in beam quality. Now, I keep pointing out that this is beam quality because what are your radiographic quality features? What do you have to make a good diagnosis?
Contrast, sharpness.
Contrast and sharpness, that's pretty much it, right? You gotta have a sharp image, and you've gotta be able to differentiate between tissue types. Well, what happens as KVP goes up? Does anything happen to sharpness? No, sharpness is unaffected, but what happens to contrast?
Goes down.
Goes down, right? So beam quality and radiographic quality are inversely proportional, okay? So I gotta keep pointing that out, that we're talking about beam quality and radiographic quality are not the same thing. So again, generator type, we talked about that a little while ago. As we change generator type, we get the reason we get that spackling in of those pulses is because we got all overlapping pulses. But what else that does is that it prevents our overall beam exposure from dropping to zero. What I mean by that is that for every pulse that you make, if you're shooting on a single phase machine, the energy, overall energy, is going to go from 0 kVp to the peak kVp you have set and back to 0 for each one of those pulses. Okay, so you get a minimally intense x-ray beam up to an intense and powerful x-ray beam, and it drops back down. Okay, so if you were to take a manual spinning top, and we'll talk about that in the QA section. A spinning top is just a small spin. It's just a spinning top. It's only about that big around, and it's solid copper, and it's got a hole in it. And if you were to find a single phase machine and you could spin that top while you make an exposure, you know, you spin it and you make an exposure, what you'll see is really pretty fascinating is that, and you don't want to spin it very fast, but if you spin it kind of slow and then make your exposure, what you'll see is that for every pulse in the incoming line waveform, you'll make an exposure and you'll have a dot on your image, as opposed to where it stops, there is nothing. So individual little bitty dots. So that's single phase. When you go to a three phase, what you get is none of those dots. It's a solid line, okay? And the line doesn't really seem to lose a whole lot of intensity in between exposures. So what that gives us is a higher average. So everywhere that you come to a stop, you don't come to a stop. So the overall beam average energy increases. So it works kind of like increasing KVP. Not entirely, but kind of like increasing KVP. We don't have as many of those low energy X-ray photons created with three phase as opposed to single phase. And even the ones that are get absorbed inside of the filtration, right? So the emission from the X-ray tube is of higher quality and higher quantity. So the beam energy with three phase and with high frequency is much higher than what it is with single phase. So when we're talking about KVP, we're talking about the peak energy, right? P represents the peak energy. So back to the brim spectrum, the right-hand end of that brim spectrum represents the peak energy, the highest energy. It's as high energy as you possibly can create. And largely that's representative of your brim spectrum. The only time that you're gonna have KVP at the peak energy characteristic is if you happen to just set 69.5 kVp. So your peak energy generally is representative of brim's creation. So as we increase KVP, we increase the quantity exponentially, and again, it's a measure of beam quality. It's what you use to affect beam quality, and it's directly proportional to KVP. All right, so what are our types of filters? Two types of filters fundamentally. We've got inherent filtration, and we've got added filtration, right? So added filtration is anything that you need to bring the half value layer of the X-ray beam up to 2.5 millimeters of aluminum or equivalent. All right, so if you're shooting above 70 kVp, your X-ray beam or your X-ray tube should have 2.5 millimeters of aluminum inside of it. Okay, so 2.5 millimeters of aluminum. Anything above that is added filtration. In some of your older tubes, if you ever work with some of your older Phillips tubes, you'll see this little dial sticking out of the collimator housing where you can adjust your filtration. Some of the really old ones, and you're probably never going to see one of those, they actually have inside that dial, they'll have copper filtration too. Back in the day when diagnostic tubes were used for mammography, then they had to have all different types of filters, and you just don't see that anymore. I hadn't seen a non dedicated mammo unit in my entire career. I've worked with those tubes, but they've never been used for mammo. Okay, so added filtration is anything above that 2.5 millimeters of aluminum, and it's also compensating filters. So we've got a lot of different types of compensating filters as well. The ability to image on CR and DR in the computer algorithm, even out contrast and density differences on tissue, kind of have taken the place of compensating filters. Anybody seen a wedge filter in clinicals?
Mm-hmm.
Have you?
Oh,
Really?
I'm sorry,
No.
what's up?
It'd be great if you had, because I think they're still relevant. Have you ever shot a lateral C-spine on a patient, you just can't get to C7T1? Yeah. That's what your compensating filters are for. You take the thick end of the compensating filter and put it over the thin end of the anatomy, thin end under the thick end of the, or thin end under the thick anatomy, and it evens out the tissue density differences. Dramatic in film, and probably still pretty useful in digital applications as well, but I think, most of your hospitals kind of rely on the computer algorithm to take care of that for them. Doesn't really get you there. So compensating filter, a lot of different types of them, and they compensate for differences in tissue density most of the time. Ever noticed on a shoulder? Probably not, but back in the day when we used film, shoulders, you had to shoot for where the pathology was. Feet, you had to shoot for where the pathology was. They had these shoulder filters that they call boomerang filters. You know what a boomerang looks like, right? So they're nice and curved, and what you would do is you would put that right at the curve of the shoulder, because in a lot of cases you would burn out the greater tubercle, maybe the AC joints, things like that on the lateral side of the shoulder. Rest of the density looked good, but that was just, too light. So compensating filters compensate for differences in tissue density. So with filtration, higher, this is really, probably should have said KV rather than KVP, but KV require higher average KV in order to penetrate through the filter itself. So you get a higher energy of the residual X-ray beam, and it directly controls your half value layer, reduces low energy filtration, or low energy photons. What's left are higher energy photons, and therefore it's a better half value layer is a better measure of beam quality than what KVP is. Takes more into consideration. about generator type, single phase, one pulse per hertz, per waveform. You do have unrectified and rectified units. You're never gonna work with an unrectified unit. Probably the only place you're gonna see an unrectified unit would be in a dentist's office, where you've got just very low energy x-rays created. Last time I went to the dentist's office, they had a handheld x-ray unit. They just pick this thing up, they put it by your face. I said, what is that? And that's kind of cute, but, you know, what are you doing with that thing? I don't hear a rotor, I don't hear nothing. But they just pick it up, it's just a little handheld unit. It's pretty cool. So you're never gonna work with them. And what we say about unrectified units is that they are self-rectified. Remember, the x-ray tube is not only a big light bulb, but it's also kind of like a big fuse, right? It's a vacuum tube diode, so that electrons go from one end to the other, but it's unlikely they're going to come back across the x-ray tube, except for where we use extremely high voltage. So what kind of voltage do we use?
Kilovolt.
Kilovoltage, which is by nature
Very
extremely high voltage. So the possibility exists that we could get electrons flow from anode to cathode, which if we can melt the anode, that big thick chunk of tungsten, by sending electrons from cathode to anode, then logically if we send electrons from anode to cathode, what's going to happen to our filament?
Destroy it.
Yeah, it's single exposure, it's done. So, we can't use those, but if they're using very low voltage in comparison to what we're using, then they don't necessarily need rectified, so they can use unrectified, single phase, single pulse x-ray energy. And they probably, you know, the tubes probably live for a long time. So the reason that we get that higher average is because the potential never drops to zero in three phase, but in both unrectified and rectified single phase, it does drop to zero. The difference between those two is that there's a noticeable pause in between the two. In rectified, the pulses just back right up to each other. Okay, so individual pulses, but they don't overlap, but they are. The time that they spend at 0 volts and 0 potential is insignificant. There's not a whole lot of time there. So with three-phase, remember we've got three-phase 6 and 12 pulse are the most common. Yeah, you might run across three-phase 3 pulse, but that would be a three-phase unrectified unit. I don't know that has ever existed in X-ray. But the potential never drops to zero. We tend to think that it would be an increase in output of a factor of 3, but it's really a factor of 2. We get an increase in average, and high frequency takes it up even a little bit more than that. How you can tell a high frequency, if you're working with a high frequency machine, is that whenever you make an exposure, you're going to hear two things. One of those things is the audible beep that you hear, you know, behind the control panel. But can you hear a kind of a whining sound out in the X-ray room sometimes, or somewhere else in the room? It may be up in the false ceiling. It could be almost anywhere. That is what they call a chopper circuit in the high frequency units. So what we get, as I understand it, with the high frequency is that, let's say we set a technique of 100 kVp. What it'll give us, instead of 100 kVp, is maybe 105 kVp. But that 5 kVp is the very top of those pulses. And then what the chopper circuit does is it just kind of takes off the top of those, so you get an almost constant potential at 100 kVp. So it gives you more than what you're asking for, but then it takes that very top portion off, so that you get an almost, you said 100 kVp, you get almost no voltage ripple. It's almost a constant potential. I was talking to a Biomed guy one time, this was years ago, and he was saying that they were working on a constant potential generator. Well, what's your you remember what your voltage ripple is on a high frequency unit?
Less than
Point.
less than 1%, so it's almost zero. So, you know, I think they were looking at it, and they thought, well, you know, we're gonna spend all this money developing this brand new technology to come to a point where we lose less than 1% of the voltage ripple. And it just kind of died in committee, I guess. So slight increase in output, slight increase in average over 3 phase. It's pretty dramatic whenever you compare it to single phase. I actually used to work in a hospital where we had a single phase. This was in the ER of all places, and they had and it was over Longview. They've fortunately upgraded since then, but Longview, Good Shepherd was at the time. It was like Longview had 2 hospitals. One was Good Shepherd, almost 400-bed hospital, and the other one was like 100-bed hospital. Just didn't do a whole lot of trauma. So we're working at Good Shepherd, and we have in one room, it's a high frequency unit, shot beautiful x-rays, worked great when it worked, but it was more of a doctor's office type machine. In the other room, we had a single phase machine. That was our trauma room. So, you know, the difference in technique between the 2 rooms was about 2.5. So if you had to shoot something in a single phase room, then what you had to do is take the technique that you knew, you know, by heart from the high frequency room and multiply it by about 2.5 to get to a technique in the single phase room. So the conversion from single phase to 3 phase is about 2. From single phase high frequency, about 2.5. From 3 phase 12 pulse to high frequency is pretty insignificant. So, you know, your technique change is minimal from 3 phase to high frequency. So, X-ray quality equals beam penetrability. Half value layer is your best measure. So the more of any absorber that it takes to reduce the intensity of your exposure down to half of its original intensity is what your half value layer is. So, any questions on that? Okay. Well, then let's take a break. Come back to chapter 9, just a little bit in it as it relates to X-ray exposure, not so much radiation.